Good afternoon. I'm Michael Rothman. Very pleased to be here, especially among such distinguished company. And today I'm going to be talking about, leveraging the EMR to save lives. I'll cover the origin of a patient acuity score called the Rothman Index, the science behind it, how it's used, and what outcomes we've seen. So as far as origins, this is a family story. That's a photo of me and my brother. My mother's sitting next to me in the main photo, and on the right, that's my mom and myself when I got married. My mother had aortic stenosis and needed a valve replacement operation. She had the operation and did well. However, over the next several days, she started to deteriorate. And without going into the details of her story, she was discharged, came back to the hospital 4 days later, and died of a cardiac tamponade. Yes, sorry. My brother and I came to understand that this was an avoidable death and wondered what had gone wrong. One of the things we came to believe was that the doctors and nurses taking care of our mother were competent. And as we looked into it, we felt that the system itself had failed. So what do I mean by that? There was a lot of data in the EMR, but still, when a nurse saw my mother on a Monday, that nurse would say, okay, this patient is in reasonable condition for someone so many days after major surgery. The next day, another nurse would see my mother, come in and say, this is reasonable condition for someone so many days after major surgery. But what that second nurse couldn't understand was that from day 1 to day 2, there'd been some deterioration. As I say, there was data in the electronic medical record, but it really functioned more or less as an electronic filing cabinet. It was there, you could look it up, but it wasn't integrated. It wasn't useful. And it was very difficult to use that data to find a trend. That's one of the things people have spoken about so far today. And so we asked the question, why isn't there a simple measure of physiological status that could be used to track patient condition, just to answer the question, is the patient getting sicker? That started us on what became a long journey. This was, I hate to say, but 20 years ago now. And a bit about my background. I don't have a medical background, as opposed to probably almost everyone else in this room. I have a PhD in quantum chemistry. I've spent my time doing mathematical modeling. And so I started addressing this problem sort of from ground zero. I said, what data is in the EMR? There were 7,000 variables in this particular EMR, and I said, all right, we'll start with all of them and work our way down. When we did this, we looked for variables that were clearly measuring physiological status, that were measured on a regular basis, and that were measured for all patients. And one of the things we came across was this thing called a nursing assessment. I didn't know what a nursing assessment was. So it turns out, I'm sure most of you do, but maybe not all of you, when a nurse comes into a patient's room, that nurse does a very structured evaluation of the patient's physiological status, actually rating each of about a dozen physiological systems in terms of have they met or not met a minimum criteria. For example, the minimum standard for the gastrointestinal assessment is abdomen being soft and non-tender, 4 quadrants of vowel sounds, no nausea or vomiting, and bowel continent. If all of those are true, then you've met the minimum standard. If any one of them is not true, then you've not met the minimum standard. Nursing assessments are recorded at least twice each day. It's part of nursing school curricula, I believe, around the world, sometimes called the head-to-toe assessment. And every hospital records this information. When we started looking at nursing data, we found that it gave us a window into deterioration which was surprising to us. You're all familiar with the concept of decompensation. When a patient's crashing, their blood pressure is plummeting, their heart's racing, they're panting, temperature is spiking. That's a crisis. But there is a flip side to decompensation, and that's compensation. And that is when the body is being challenged, but is managing to maintain vital signs within a reasonable range. The idea of homeostasis. And what we found was that during this period of compensation, things would happen that the nurses picked up, such as the patient stopped eating, they became confused, they became incontinent, they developed edema, they had trouble walking, their digestion shut down. All these sorts of things are picked up by the nurses, and that gave us a window into what was going wrong before the crisis. The problem that we realized in terms of depending on vital signs was that they tended to tell you when there was a crisis, or maybe when there was an imminent crisis. But if you wanted to prevent a crisis, it was valuable to look further back in time. When we started using nursing data in our model, we came across a lot of skepticism. People said nursing data is unreliable, it's not repeatable, it's actually a lot of noise. That's where my training as not a medical person, not having a medical background, came to be useful, because I didn't have any bias against nursing data. We did a study. We looked at 40,000 patients from a couple year periods at a hospital, and this is what we found. These are odds ratios. The way that you read this is, and we're looking at the first assessment upon admission to the hospital. The way that you read it is the patient is 9 times as likely to die in the hospital if they fail their neurological assessment at admission than if they pass. They're 8 times as likely to die in the hospital if they fail their respiratory assessment at admission rather than if they pass, and so forth. We then looked at the final nursing assessment taken just before discharge, and we saw the same sort of thing. Now we're looking at the likelihood that the patient's going to die in the 1 year following discharge. And we found that if you failed your food and nutrition assessment, you were about 7 times as likely to die in the following year as if you passed, and similarly with neurological and psychosocial and so forth. And so this is what we came to understand. If the first nursing assessments taken upon admission correlate with in-hospital mortality, and the last nursing assessments taken just prior to discharge correlate with post-discharge mortality, then it's reasonable to infer that all nursing assessments gathered throughout the patient's stay contain significant clinical information. We published this back in 2012. We took our own path in terms of building a model. We built a heuristic model that is constructed, not a regression model, and it was based on a methodology which we called the excess risk method. And this is how it works. The graph on the right there shows 1 year post-discharge mortality, and the x-axis is serum creatinine. And what we did was we had data on 25,000 patients. We ordered them from low creatinine to high. We then bucketed them. For each bucket, we looked at the average creatinine and the mortality rate, and we got this nice U-shaped curve. Now, as I said, with no medical background, I wasn't sure exactly what it meant, but I spoke to a lot of physicians. I understood that high creatinine correlated with kidney disease, low creatinine with muscle wasting, and there was an interesting, very flat part of the curve which went from 0.6 to 1.1. We went to the pathology lab and said, well, what's normal for creatinine? They said, well, the normal range is 0.5 to 1.2. So we were able to find the normal range directly from risk data. Once we saw this, we said, okay, let's apply this to everything. And so we looked at, here's another one. This is looking at heart rate. Low heart rate is bad, high heart rate is bad. But you see the yellow line superimposed there, and I think Chris and Brian would recognize that. That's the risk function from Muse, I think it's the same in News, for cardiac, for heart rate, which says that between 50 and 100 beats per minute, there's no extra risk. Between 100 and 110, you get 1 point of risk, 110 to 132, and so forth. But the thing that's interesting is that our excess risk curve looks like it was drawn right through that step function. And so not only were we able to identify the normal range, but we're able to identify the escalation in risk as a function of deviation from that normal range. So we did this for everything and came up with a set of variables that spanned the different modes of decompensation, or deterioration rather, modes of deterioration. You'll see a list of vital signs that are familiar. The nursing assessments, we used the Braden score, which is another nursing measure, various lab tests, and cardiac rhythm. And we calculated excess risk curves for each one. One thing, why is it called excess risk? Well, even for, for heart rate, having a heart rate of 55 doesn't guarantee that you have 0 one-year mortality. The real mortality rate in this population was about 7%. So we subtracted that 7% from all the numbers. So it's the excess in risk above the baseline. That's why it's called excess risk. And so this is a summary of what has become known as the Rothman index, named in memory of my mother. And if you look at the first row, the second graph in, that's the heart rate curve that I showed you before. The third row, the first one in, is creatinine. And each of the others are in this diagram. There are 26 inputs to the score. The lower right-hand corner are nursing assessments. They're binary, so each separate nursing assessment is represented by a bar. And this was published in 2013. It was difficult to get it published because we were doing something different. But when it was published, it was selected as one of the best papers of the year at the AMIA conference. And since then, there have been more than 100 peer-reviewed either articles or conference presentations, and there are more studies underway. So the problem when you create a heuristic model is it doesn't guarantee that it means anything. You're just constructing it. So what we had to do is we had to show that it was a valid score. So the graph on the upper right is showing 24-hour mortality from 3 different hospitals. You can see as the RI falls, the likelihood of dying in the next 24 hours increases. The next graph is 30-day readmissions. Lower score, higher readmission rate. The bottom one is correlation with the Apache 3 measure of mortality. This was looking at the initial RI. So the first bar, the green one that has 90 there, those are patients admitted with RI scores between 90 and 100. And the y-axis showing their average length of stay. And so you can see the lower the score at admission, the higher the length of stay. The graph on the right shows the cost as a function of initial RI, also correlates. We looked at correlations with discharge disposition. Those patients who went home had a higher RI. Oh, I should say, high is, it's like a grading system. 100 is good. So 100 means unimpaired. The lower the score, the sicker you are. So discharge to home had a higher score than home health, than rehab, and so forth. This was looking at length of stay in the ICU as a function of RI at admission to the ICU. This is separately for a MICU and a SICU, and you can see the lower the score at admission, the longer the stay in the ICU. Okay, so how is this used? So it's valid, and it's telling us something. And one of the ways that I think is most important is just in improving communication. And I think that's kind of one of the underlying messages of today. This was a sentinel event at a hospital. The chief medical officer came to us, this was before we had a system installed anywhere, and said, we looked at the medical record, we didn't see anything. Take a look, see if you can find something. At that point, I was calculating the score 1 point at a time. And I got 70, 80, 78. I thought, well, I'm not going to see anything either. And then I saw this 50, I should say, each one of those vertical lines is midnight, so you're looking at about 7 days of patient stay. We saw this 50-point drop, this huge signal. By the way, this was a 46-year-old male admitted by a podiatrist with a foot ulcer. So why did we see this big signal and the physicians who were looking at the medical record didn't? And this is really the answer. So from 7:30 in the morning to 8 o'clock at night, you can look at the top row, and you can look at the vital signs across the top and the bottom row, 8 o'clock at night, 12 hours later, and you can look at those numbers. And I think you would agree that there's nothing that would have gotten a physician's interest. And so what did we see? What we saw was the Braden score had fallen from 18 to 12. They'd failed their food and nutrition assessment. They'd failed their GU assessment. They'd failed their neurological assessment, their psychosocial, and their safety assessment. And the nurse who was taking care of this patient said she knew something was wrong. The patient was hallucinating, they were incontinent, but she couldn't get the attention of the physician because the vitals were still hanging in there. So this turns out to be a tool to help the nurse raise his or her hand and say, please take a look. The main use is in proactive rapid response. Again, each one of those vertical lines is midnight, so you're only about 5 days. Each one of those dots is a new RI score. It's recalculated every time a new piece of data is entered into the system. There are 3 green dots there. You can click on a dot and it'll show you what the input was at that point. And the color coding in the table on the right gives you an idea of the impact that particular value of that particular variable had on the score. And since these graphs are in effect in the computer, we monitor them continuously, and where we have 3 levels of concern looking at changes in the score. So the yellow shading underneath was our first level of concern. The orange, we got more concerned, and the red was our highest level of concern. Palliative care has been mentioned a little bit. The graph on the left is a patient the last 5 days of their life. And if you can see, there's a gray vertical line there. That was when there was a palliative care consult. That was just about a day before the patient passed away. Unfortunately, the graph on the right is that same patient. They were in the hospital for about 6 weeks. After about 10 days, they were in terrible condition and maintained that awful status for about the next month. If you could have moved that palliative care consult to the left, a week, 2 weeks, it would have been very valuable to that patient, to the family, and to the hospital. Okay, so what results have we seen? People can do modeling, but the real test of a system is You have a hospital, they have certain operations, you add something on, what's the delta? So it doesn't matter, in a theoretical basis how well you can predict something. What matters is how well are you affecting outcomes. And that's a whole different topic, but this was at a community hospital, part of the Yale system. That bottom line, they implemented what they called a SWAT team. So they had ICU nurses rounding on those patients who had triggered an alarm. The line at the top is the main hospital during the same period. There was a 30% reduction in mortality. This was another hospital in the Yale system where they saw about a 20% or a 30% reduction in mortality before and after implementation of the RI. This was a study done in Florida looking at the comparing rapid response calls and transfers to the ICU. They found a reduction in unplanned transfers to the ICU using proactive rounding. So the nurses were monitoring the RI. Instead of waiting for the bedside nurse to call, they rounded on that patient and reduced unplanned transfers to the ICU. This was another hospital, Blessing Hospital. They had what they called a high acuity response team, focusing on those patients that were the sickest. They reduced their mortality index by 30%. This was published in 2022. The latest study I would love to give you the results on, but unfortunately it's in review at a journal. I'm sure a lot of you know about that process. But what they found was a reduction in mortality, reduction in length of stay, and a reduction in unplanned transfers to the ICU. In terms of case studies, this is the case I was talking about with regard to Blessing Hospital, and having these dedicated ICU or dedicated high acuity response team nurses made all the difference. It's another case study at a hospital in California called North Bay, where they were able to reduce unplanned transfers as well as mortality. They had integrated it into not only nursing rounds, but they have clinical meetings hospital-wide looking at those cases that are of special interest. We're at Akron Children's Hospital. They again saw a reduction in unplanned transfers to the ICU. You don't really see an impact on mortality because mortality rate at pediatric hospitals is very, very low to begin with. And so if you think back over what I've said, one of the things, well, it's important to have a model which is capturing what's going on, but it is just as important to have the right protocols associated with it. Unless whatever it is knit into the fabric of the hospital, it won't be successful. And so what we've found in a lot of these cases is kind of a one-to-many view. Instead of having every nurse use the RI, having the rapid response team people, having a central control area where they're reviewing RI graphs, or just having the charge nurse review graphs, having the hospitalist who's responsible for 10 to 20 patients, probably none of which he or she is familiar with when he or she first comes on service. And so that was a way to leverage this, leverage the opportunity to get to the bedside when it still would make a difference. So, I have told this story. It is, as I say, a story about my family. I've talked about the science, nursing assessments, machine learning, being able to extract information directly from the data was very valuable and exciting. Putting everything on a common scale, how we validated it, and then how it's been used as a communication tool for proactive rapid response, for surveillance. It's used for sepsis detection, and I agree with several of the speakers talking about sepsis. Sepsis gets a lot of attention, but the way to reduce sepsis mortality is just to focus on who is sick. And so if you do that, you reduce sepsis mortality. And it's valuable in terms of palliative care. Outcomes, we've seen reductions in transfers to the ICU and in mortality. And this idea of one-to-many is something that we have found to be useful. And there are a few references here. I think they're in the handout. But thank you very much. I think I'm still in time. So thank you.